Thank you for joining today's Health Education and Learning Program webinar, ACO Implementation, a Team Sport. The National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. As the nation's leading technical assistant and knowledge center in rural health, the center focuses on 5 core areas: transition to value and population health, collaboration and partnerships, performance improvement, health information technology, and workforce. The center is committed to building a culture where difference is valued. The center is committed to DEI and anti-racism. We create an environment that reflects the communities we live in and serve, a place where everyone feels accepted and empowered to be their full, authentic selves, and where everyone belongs. We understand the impact of and seek to defeat racism and discrimination in ourselves, our workplace, and the world. This guides how we cultivate leaders, build our programs and resources, and deliver our technical assistance. We are an organization that honors, celebrates, and respects all dimensions of diversity. These principles are central to our mission and to our impact. Rural Health Innovations is committed to DEI as well. By attending today's webinar, participants will be able to describe the steps to engage their team, name the qualities necessary for a successful physician champion, explain the process of involving the team in ACO participation planning, identify the role each team member plays in success, describe ways to celebrate and reward changes needed for success. With that being shared, I'd like to welcome our guest speaker, Dr. Kleberg. Dr. Kleberg is a retired family physician with experience in assisting physicians and clinic leaderships to achieve their goals in value-based care. His most recent accomplishment has been Regional Medical Director with Alidad, where all his ACOs reduce the cost and increase quality of care, while more than half of his achieved shared savings checks. Among his other accomplishments have been serving as the Chief Medical Information Officer for Stratus Health, the Medical Director for Clinical Decision Supports at Health East Care System and for Allina Health. And he has been board chair for HIMSS, so the Health Information Management System Society. He's led meaningful use committees for the Office of National Coordinators of Health Information Technology and clinical lead for the team implementing the Epic ambulatory system at Allina. He started his medical practice providing the full spectrum of family medicine in small independent practice in St. Peter, Minnesota, and later he worked in a suburban ambulatory practice in Ramsey, Minnesota, part of the Allina Health System. Using the ambulatory EHR he has helped design. Dr. Kleberg comes with a vast experience in value-based care and the implementation of technologies, including telehealth, to improve provider workflows, care quality, cost savings, and patient experiences of care. We are honored to have you with us this hour, Dr. Kleberg, and thank you for joining us. I'm now going to turn it over to you.
Thank you, Kiona. I appreciate that. Now let me get this set here. I'm a little technically challenged today, folks, so bear with me.
Looks perfect.
Okay, you should be able to see my slide deck. Well, good afternoon, everyone. I don't know where it is where you are, but right now it's a rainy and a kind of damp day down here in Apple Valley, Minnesota. I'm also, I think it's about 6 days post-operative left shoulder replacement. So I'm a little bit under the weather today, and pardon my attire, but it's hard to change clothes when you're in a sling. So thank you, Kiona. Again, she already talked about our objectives that we're going to cover today. And it is important that we want you to understand how you can engage your team, the qualities necessary for a successful physician champion, the process for involving the team in planning, also identify the role each team member plays in the success, and describe ways to celebrate and reward the needed changes for success. So here are the steps. Right at the very top, and we'll talk about this more when we go to each individual, executive leadership and support is absolutely key. I've had a lot of experience with executives that are fully behind it and some that are only half behind it, and they set the tone for the rest of the team. Your physician and nursing champions are important folks that we'll talk about in a little bit, and selecting the right ones for your organization are going to be important. And we'll also need other champions from among your staff, because no one really knows all the workings in all the different areas of your organization. And you really need to have a voice from each section to both show the way and provide feedback on how things are actually working. This group really needs to understand the value and scope of the undertaking, and they need to be involved in the implementation and workflow design as you do it. So as you start your process, we want you to start with bite-sized pieces, reward small wins, and review and aim to continuously improve. So let's start at the top. Executive leadership really needs to understand the scope and the value of the change. In early February, I think it was February 2nd or 3rd, we talked a lot about the different components for success in an ACO and how they provide value both to your ACO and to your patients. Well, it's very important that the executive leadership understands the value of that for both the organization, the providers, and the patients, and also understand the scope of change that this may mean, and be open to a lot of feedback from your staff that are doing the implementation, and also provide the needed support that they're going to take in order to devote the time to do this. So you're fully behind it. They are prepared to devote the resources necessary for success. The leader is will need to know how to work collaboratively to identify the team champions, so someone that you can work with, and also someone that you believe will function well as a team champion, and provide support to the team for the success of this particular project. So let's talk a little bit more about selecting your champions. First and foremost is the role of the physician champion. This individual needs to be an example to their peers. They're going to assist in reinforcing the value of the transition to staff and their peers, exist in as the clinical voice on the leadership team, and demonstrate how it can be done. It really does not matter that this person is an MD or DO, but they need to be a provider, and a provider that is actually respected within the organization. In the roles that I played with some of the ACOs that we've had in one particular group of community health centers, rural health clinics, the leader was supported by the physician leader, was supported by the organizational leader to devote the time to be able to do this. He was well respected, and he was able to do a good job of incorporating it into his own work, and consequently was a good example to others on how it could be incorporated into theirs. I'm trying to adjust something on my screen here, excuse me. Here we go. So what makes for this person to be effective? And I talked a little about this gentleman that we used within the community health centers. They need to be a respected leader in active practice, someone who really gets what we're doing and knows why we're doing it. They're willing and able to devote the necessary time to implement this. They feel supported from leadership. They provide quality care, and they're a good listener and problem solver. Many times leaders are very good at doing presentations and very good at telling people what to do. But in this situation, it's really important that this individual is able to listen and understand what folks are going through and try and work together with them to solve problems. In that respect, they need to be very open to feedback so that they can bring that back to the leadership team, and also so that they are showing to their peers that they understand the challenges that they're having. All right. So there are a lot of common mistakes that I've seen in selecting a physician champion. Sometimes they'll choose a new physician who just came on board to take this on as a project. But obviously that new physician is not going to be really well established in the history of that practice or the organization and how things are done. And I've seen how this new physician will get relegated to, well, you take care of it and we're just going to keep on doing what we usually do. And then really nothing happens. It's a miserable failure. And that physician feels pretty frustrated. Another person you want to be careful about is choosing the busy medical director, because they've got so many things on their plate already that if this adds yet another thing, unless they have the dedicated time to do this as actually cut out of their clinic time or their daytime, it's going to be something that's just going to fall by the wayside. And you don't want to choose someone solely because they appear to have extra time. The importance in this particular position is someone who gets it, who provides how to do it, is seen as a respected leader, and is also a good listener and problem solver. And they're also good at bringing back information to the leadership team on some of the challenges that are happening so that changes and improvements can be made. So the next important person on your team is the nursing champion. Again, many of the same qualities are necessary as what you see with the physician or the provider champion. And these folks are really very familiar with the staff flow. They may be doing huddles in the morning or any number of particular organizational activities to make the workflow flow within the practice so that the patients are seen efficiently by the provider and all their needs are assessed. So they will assist in reinforcing the value of this transition to their peers, viewed as the nursing voice on the leadership team, and is willing to incorporate new ideas, and again, feel supported by leadership. I've seen in some organizations when they pick someone who really understands what they're doing, they can change the world. Again, we need to have someone who is a team player, understands what the other folks are going through, and is a good support and has a vision on how this is actually going to work. So we'll also need to engage some of the other champions in the organization, depending upon the structure of your organization. You know, one of the persons that's going to become more important is the front desk. They're going to be the first person to see the patient. In some instances, they may be the individual who's reaching out to patients to bring them in or to check up on them. The scheduling team is going to need to make sure that we can get in wellness visits as they're needed, or transitional care visits as they're needed. Be able to see if there's actually enough time on the schedule to be able to convert a follow-up visit to a wellness visit that can be billed as a wellness visit. The coding team is going to be paying attention to what's on the ticket to make sure that the codes that actually carry weight appear higher up in the hierarchy of submitted codes. They'll also be potentially doing reviews of the electronic health record to find patients that have depression single episode unspecified, so we can begin to correct that, because that again is the only depression code that does not carry weight. Your care coordinators may be reaching out to high-risk patients to get them to come in, or checking in to see how they're doing, and we'll talk more about that in a bit as well. And again, your data collectors and integrators, those are people will be looking at data within the chart, getting information from the hospital, from the skilled nursing facility, any of those places that the patient's been to, so that it is there and ready for when they come in and see the provider. And there may be others too, depending upon your structure and network. And that will come clear as you begin to implement this particular process. So now we need to really involve the whole team. I talked about some of the things champions are doing, but it needs to go even further. Everyone is going to recognize and understand that this is complex. Just what I mentioned, the champions that need to be involved, it hits absolutely every aspect of your organization. And you'll need feedback and information from across that organization. No one person knows how it works throughout the system. It involves more than one discipline or work area, requires creativity on everyone's part in order to be able to adapt to what you have and do it in a gentle, achievable way. And gaining that staff commitment and buy-in are absolutely necessary. So this high performance team that we have, this team of champions, need to have a clear and shared model and understand a mental model of what we're doing, understand their roles and responsibilities, have strong leadership, engage in the discipline of regular feedback, develop a strong sense of collective trust and confidence, create mechanisms to cooperate and coordinate, manage and optimize performance outcomes. Now, there are a couple of tricks that some of the providers or some of the medical directors that I had that were leading an ACO did on their own that actually made a very significant difference. One of our medical directors in Louisiana started what he called a doctor's lounge. And once a month, he would have, in the evening, he'd have his telephone open, he'd start a Zoom call, or actually we used something else at that time. And he would just be present. And he would throw out a few topics for folks to discuss. And it gradually got more and more engagement from the providers because they really wanted to know how each other were making this work. Because they were all bought into the fact that they wanted to do this because there was benefit to them to doing this and a benefit to their patients. So this became a self-sustaining process of engaging all of the physicians and troubleshooting problems that each of them were having. We had another instance within the parent organization. At that time, I was working for Alidade Incorporated. And they had a monthly meeting where a topic would be discussed, say wellness visits or transitional care or COVID or something that was key to their practices at that particular month. And they would, again, go through some of the issues that were important to it and why it was important to do this. And they would also have a guest speaker from among the providers that were already doing this on how they had accomplished it and what they had discovered when they did this. And again, that was very valuable. And the interaction between the doctors was great. So these are many ways that you can begin to involve the team. So we want, as I mentioned, we want to understand the scope of the value and the value of the undertaking. And it needs to be the entire staff that does this. That everyone needs to know that some processes will be modified, some will be added, and everyone's going to need to participate on some level. So we talked about these last month, and each needs to understand the value of the wellness visit. The wellness visit is a good preventative visit. It also is financially valuable to the practice because it can reimburse 30% more. Accurate risk coding allows you to represent the disease burden of your population and consequently the expected costs of that population. So when you provide cost at less than expected cost, you achieve savings and you get some of those savings back. Chronic care management is going to be taking care of those patients who are out there who need additional support in order to follow their program. Transitional care management, we know the value of that is that about for every 7 transitional care managements that's done, we reduce 1 hospitalization in that, or rehospitalization within that 30-day period. And emergency department follow-up, we know that it's important because we want to know why are patients coming to the emergency department as opposed to coming to see us? And is there something that we need to do to let them know that they can come and see us and they can contact us? So once this is all clear to the team, then we need to transmit that belief to the rest of the organization. And really this component is critical. It starts with your champions. The team sees how it can be worked into the current workflow, and they share this belief with the staff. And they evangelize. Now it's time to spread the word, and spread the word includes reinforcing the value, assisting with the workflow, listening to the challenges, and providing feedback to the champions. So once again, your champions need to be good listeners, need to be good problem solvers, and need to provide feedback to the team because we want everyone within the organization to work at the top of their license. And because someone was doing it, it doesn't mean they need to be the one that's doing it. Maybe there's someone else can do it to free that person up for things that is really more part of their license to do. So Now we're going to talk about how do we make this work. First thing you want to do is identify what you're already doing well. These first 3 steps are going to help you identify where you want to start. You then also want to identify where are the areas that you have the greatest opportunity for improvement and decide which could provide the greatest bang for the buck. And we'll talk about some examples in a little bit. It's really important to identify these small successes in order to build momentum. You want people to feel like that they're doing it, that's positive, and it's making a difference to their patients and to their population. And consequently, you want to start with bite-sized pieces that can provide success. So let's go through some of these things that we talked about last time and talk about the people that are going to be engaged in making each of these components work. So for annual wellness visits, we know that they're important because we're going to do a lot of preventative maintenance with them. We're going to review their history and make sure that we've got all the information that we need about them. We're going to establish a care plan, and we're going to renew and review any of their problems and set up further visits as necessary. So the data persons are going to need to keep track of the patients that are due. They can either do it by searching the chart and prioritizing those patients based upon their risk score, if you're able to capture the risk score. So a person who's not been in the appropriate time period yet, but has a high risk, you want to see if you can bring them in for 2 reasons. Number one, getting them in and coding them appropriately will increase the expected cost for your patients. And when you provide quality care at a lower cost, it's a win for you. And obviously it's also a win for the patient because it may have kept them out of the hospital or the emergency department. Care managers may reach out to some of the patients that they're working with that are due for a wellness visit and explain to them why it's important. They could also be empowered to be that outreach person, or it could be the front desk. And they can also identify those patients when they come in, if they, for any reason, to see if maybe we can do a wellness visit at the same time. Now, I talked about this last month. If they're scheduled for a follow-up visit, you can still do a wellness visit and bill for a wellness visit alone. You can't bill both in the same day unless you're in private practice. That wellness visit is actually worth about 30% more in terms of your benefits when it comes to how the practice gets paid. And if there are no labs drawn or anything other that's a billed service, it's actually free because it's a wellness visit. A wellness visit does not mean you cannot assess their diabetes or address other chronic problems during that visit. Some coding staff have a challenge with that, but that is absolutely true. So you can do it as a wellness and do the chronic care as an add-on without billing specifically for it. So the rooming staff are going to talk of the benefits if the patient has not had one, but if they are there to have one, they'll collect all the information that is due in order to have the information ready for the provider. And the nurse will review the clinical information and potentially prepare recommendations for that care plan. And finally, the provider reviews, signs off on the care plan for the patient, and also codes those elements that are accurate and that carry weight. And we'd also like that to be in the order of those that carry the most weight. If your EHR can provide that for you, or some other tool that you have can let you know what the expected weight for those diagnostic codes are. So when it comes to risk coding, we talked a little bit about this earlier. Again, it's critically important because it represents the disease burden of your population and the expected cost. So that's how you can achieve savings. The nursing staff can review for missing diagnoses during the wellness visit. Now, during the wellness visit, you don't have to do a thorough assessment of each of those elements that you're coding for during the wellness, as long as you have some information about it in the chart and you just do a brief documentation. Let's say diabetes stable, is following up every 3 months, just something short, and then it can be billed at the level that's appropriate. It could be diabetes with complications. It could be diabetes with with peripheral vascular disease, etc. All of those carry weight as opposed to just saying diabetes. So some places have products like I2I that knows what's been built in the past. I mean, there are many different ways that can be collected and presented at the time of the visit. The care manager can use specific codes when billing for care management services. So when the bill is submitted, any particular topics that they talked about during that monthly billing cycle can be added on as a code to what they have addressed with the patient. And the coding staff in the back end are going to really be doing the lion's share of some of the work here. Proactively, they can identify unweighted codes that would carry a weight if more specific. And it's good to start with the common ones like major depression, single episode unspecified, or diabetes without complications. A couple of ways this can be done is you could, if your EHR or your data collection system has a way to be able to search for those particular codes and you identify those patients, you may provide a list of those patients to your provider and gradually work through them so that the diagnoses are labeled as correct. You could put a note in the chart that the diagnosis needs to be updated. And I would start with one. These two, major depression and diabetes without complications, could be some of your early wins. Because let's say, for example, you're able to, let's say your first goal is to identify 5 major depression single episode unspecified and more accurately coded. And bingo, see who gets there first. And then they get some sort of reward and a celebration. Could also be true with diabetes without complications. Again, they then need coding staff. It will be important for them to sort these codes before submission to assure weighted codes come first. Now, some EHRs that we were working with, we discovered, even though you put 12 codes in there, only 4 would be sent. And that was a limitation of the EHR. It was not a limitation of any other place. So some were 4, some were 8, and some were 12. So we want to make sure that whatever the current limitation is, we want to fix it if it's limited and make it appropriate so it's submitting all the appropriate codes. But also we want to make sure the coding staff can make sure that the ones with the highest disease, that represent the highest disease burden, come first so they're actually counted. There's one other line here that I did not include with the coding staff. It's going to be important for them to provide a feedback loop to the providers. So potentially before they submit the code, when they look at the chart and that they believe this patient has more complicated diabetes or has something other than single episode unspecified. In fact, for recurrent or depression, that could also be unspecified and be okay. Really, there are a lot of other different depression codes that are okay, just not single episode unspecified. So the coding person, you go back to the provider with the chart, ask them to verify that, for example, if you're starting on major depression, that this one is true, or if you're diabetes, just starting with that one, if this one is true, then it can be corrected before the bill submitted, and bingo, you got to win, add those up, have a party when you've discovered X number of those have been submitted. And finally, the provider is the person who really pulls the trigger on the codes. Some EHRs provide that risk weight. Some of us have created risk weight tools that I talked about, that I talked a little bit about in the last call on a patient that was coded more specifically and less significantly, and how it made their expected cost rise from $3,000 to $10,000 to $24,000 per year. So it's up to the provider to try and do their best and pay attention to that, but also expect to have some feedback loops as they're learning how to be able to do this, because they're going to be the folks that are identifying these risks and putting them on the chart. Care management has been found to be very valuable. And as I mentioned last time, you want to be careful about care management. You just don't want to outsource this to a care management program that'll find every patient in your practice that has 2 or more chronic conditions, because they're going to be seeing and working with a lot of patients because they get paid by the patient that they see, and you're paying them to see them and potentially increasing costs unnecessarily and losing shared savings. So you want to be careful about how you manage your care management. Again, data staff can identify patients that are at higher risk. One of those things that we did at Aledade was run a list of those patients who had very high risk and looked at the ones that could be the most high risk for COVID. We created a call list for them. We called them to check in on them, see how they were doing, made sure they were able to get groceries, made sure that they had their medications. Basically, it was a check-in on them. And that was found to be very valuable. The patients appreciated it, they liked that. And we also prevented a lot of untoward results as a result of making sure that they did have their medications and they did not feel alone. So the data staff are really the people who can collect those patients and identify that are thought to be at highest risk if they haven't come in a while and need to be seen. The provider can identify patients that would benefit. So let's say someone has just gotten out of the hospital and is going to need some extra care for the time being. We can set that up. And it really works best if you do some kind of a warm handoff with the care manager, or the care manager calls, but something that we initiate and we begin to follow up with the patient, because we don't want them to fall through the cracks. And again, the care manager here will get permission, document the time spent, and code for those issues that are being managed. Patients really like these care management calls because they really feel supported, and the care managers really like doing them if they have the dedicated time to be able to do it. So for transitional care, again, we have a staff person who's watching for the hospital or skilled nursing discharges, and someone is then reaching out to that patient to schedule either an in-office visit or a virtual visit, because again, transitional care can also prevent hospital readmissions from hospitalizations. So medical records will collect that information from the stay. The nurse will review the medication and prepare the patient for the provider, and the provider will assess the patient either face-to-face or via video and create a care plan. We know that visit can happen within 1 to 2 weeks. And again, it is shown to very significantly decrease hospital readmissions. And this again was talked about last time, and everyone needs to be aware of that. Because yes, it will save money, but the other key thing here is that we're keeping people at home and in their own bed. Because so often there's so much confusion about medications and what the follow-up plan is after being discharged from the hospital. And I can say that personally, as of last week, that discharge was kind of messy. luckily, as a physician, I knew better. Oh. ED follow-up. Now, this is this is one that you want to reach out to the patient. It can be any staff person. Watch for the discharges. Contact the patient to see if their needs were met during that ED visit. And here we also want to understand why they went to the ED. Was it because something that happened suddenly? Was it because it's been a chronic problem and they didn't think that you'd have the time to see her? Were they unaware that there was time dedicated for ED follow-up or for those urgent needs? Did they call the practice and they said someone was going to call them back and no one did call them back, so they went to the emergency room? I mean, you want to understand why. Many times I've seen the provider tell the patient, come to us first. And I do not hear them ask, why did you go there? What stopped you from coming to us? We really want to be able to see you because we know you best. And that change in attitude and delivery of message, I think, is critical. We don't want to attack our patients for going to the ED. We want them to know that we want to take care of them, and we want to do what we can to make sure that their needs are addressed. And also during that call, ask if they want to talk to one of the clinical staff. Medical records, again, here is collected the discharge information and put it into the chart, so it's available for clinical staff or anyone who calls. And if the clinical staff do call, they answer any questions, review the medication list, and if appropriate, recommend a virtual or face-to-face visit with the provider in order to clarify any of the questions or problems that they have. So we talked about this, and this component really is key. You want to celebrate your small wins, create a sense of victory early in the process, which creates momentum, and you want to create these many short-term targets which are achievable are less expensive, have lesser possibilities of failure, and contribute to the long-term goal. And I gave a couple of examples already. One example is, let's transfer X number of patients who have major depression single episode unspecified to more specific code. And once we do that, let's have a party. Let's have a little celebration and understand who was successful and how they did it. It could be, again, it could be the diabetes component. It could be a workflow that's done in the practice so that the information is collected. It's how you get patients to come in for a transitional care visit, how you collect that information, any little thing. Typically, when we start working with ACOs, our first targets are wellness visits and risk coding, making sure the RAS score is accurate. And then we move on to the next things like ED discharge, hospital discharge, and care management. Again, the key here is to be able to reward those who've been successful, spread the word on what they're doing, and build success as you go. So how do we make this stick? You want to drive for continuous improvement by monitoring benchmarks and learning from individual experiences. I talked about that in a moment previously too, by those two medical directors who either had a physician lounge on a regular basis, specific topics that were mentioned, and or the intra ACO discussion on how you do wellness visits, how you do XYZ, and someone presenting on how they did it well, someone more experienced in it, and then the group discussing afterwards. By having these ongoing meetings and challenges and learning from some of our data where we need extra work, this can help for the continuous improvement in this project. You want to also discuss these success stories related to these initiatives on every given opportunity, because these will begin to foster change. And when you have regular meetings, even if it's just 2 or 5 minutes update on how we're progressing on this ACO transition, that helps keep it on everybody's mind. We want to make sure it's frontmost. With the EHR implementations that I have done when I worked at Alina, the CEO there had the implementation as first, second, and third priority for the time that we were implementing, and all hands were on deck. He had an executive team that worked together on that. I was on the ambulatory team, the physician lead on the ambulatory team. We built the product, we went through the workflow, we did all those components, and we were supported by the CEO to do that. Consequently, that was a huge success, and we won an award for the implementation in our hospitals and our clinics in a very quick way. And Kaiser actually learned from us. So we do want to make sure that it stays high on the priority so that it's continuing to be on everyone's mind. Through those meetings and through those discussions, you'll ensure that these changes become an integral part of your organizational practice. It's going to require that continued executive support of the champions, and we want to provide examples of and reward successes as we progress forward. So just to review, we talked about executive leadership. They need to understand the value in doing this. They need to be willing to devote the resources that are necessary to doing this, and they need to be engaged with their leadership team, their champions, I should say, in order to make this successful as a colleague and the chief problem solver for the organization. Your physician champion, nursing champion, other team champions are the ones that are truly understanding the individual processes within their own area, that they see how it can be done. They share that experience with others on how it can be done. They also bring back some of the challenges and some of the obstacles that they've noted to the leadership team with the executive, so they're their own subgroup. And again, we have already clarified the value and understanding when the team believes it can be done. So that belief is key. Those champions, again, are involved in the implementation and workflow design. Start with bite-sized pieces, celebrate small wins, and continuously review and provide your process through things such as office hours. It could be doctors' lounges. It could be regular grand round meetings, with this being a part on the agenda, etc. So all of these are particular ways to help make this be a success and help make it stick. So with that, I will end, and I am open to any questions that you have. Be happy to answer any questions.
Dr. Kleber, this is Rhonda Barkas. Thank you for this presentation. And I do have a question. I'm wondering if you have any tips for us on actually recruiting the physician champion. Because I appreciate knowing like kind of what to look for, what not to include, but any tips on how to get somebody on board?
Well, I think the important thing that you need to look at is you need to understand, you need to find someone who really understands the value in doing this and is willing to do it. Now, if you don't have anyone there that sees the value in it, you've got more homework to do and be able to present to the group in the organization that this is a transition that we want to make. Because as I stated last time, this is of terrific value to both the patients, to the practice, and to the providers, because it really adds value on many different levels. Now, again, when we selected physicians within our ACOs, there were ones that were leaders, and there are some that just did not seem to be interested in doing that. That's again why finding someone who can do something like this, as I said, is a good listener, is open to feedback, understands very clearly how this can be accomplished, and can work collaboratively with the executive director to make this happen, is the individual that you want to identify. And if you don't have anybody in the organization at all that fits that role, then you've got a lot of homework to do, because without having someone from the provider group being fully engaged and can be the cheerleader for this and the example for how it can be successful, it's going to be a very tough project in which to be successful.
Sure. Yeah. And so it's so important to get the right person. So I'm wondering then, as a follow-up to that, would it ever be appropriate to kind of grow your own? So maybe you have a provider who has a lot of those qualities, but maybe is not an expert on ACO or doesn't have a lot of knowledge.
Absolutely. One of the medical directors that we had for one of our ACOs, I can say it because I am one too, was an older physician, almost old codger physician. He didn't know anything about this stuff, but he took it on, he learned it, and he was a great evangelist for the rest of the team because everybody knew him. He was the grandfather of the organization. And he just made things happen. He'd waltz into any particular practice and say, how is it going, blah, blah, blah. And that's sort of esprit de corps, whatever you want to call it, moved mountains in that particular group. Again, we need to find someone who is a respected leader from a clinical perspective. And they may not know anything about an ACO, but hey, these providers are smart people. They can be educated on it. And if they really do understand the value, they will get it and they will move forward. That's, again, the provider that I think I talked about that worked in the community health centers. He was given a lot of time by his executive director to do this work. He didn't know anything about it, but he started doing it in his own practice, started doing the wellness visits, started to do the risk coding, started to do all that component, troubleshooting that himself. He really believed in it once he understood what we were trying to do, and he was a great evangelist. So the individual does not have to be well-versed in ACO. Yes, they will need support in learning about it and understanding the components, but they don't need to be experts. It's more important that they know how to listen, they learn the process, they understand it, and are able to communicate that with their peers.
Okay, thank you so much for that. I appreciate it. Oh, sorry, go ahead, Brad.
Yeah, Brad in North Dakota. I think that idea of grow your own is, in a way, the approach that we're likely taking in North Dakota. We have an initiative that we're starting, and it is basically kind of getting a lot of this in front of a group of rural providers.
Right.
and really doing some initial assessments on things related to moving into volume. Moving into value.
Right.
I know, yeah, one of the issue I know we have, and we work closely with a group of rural DONs, and I brought this up in front of them, and because we want to get the nurses in front of this and get them engaged, and I have somebody outside North Dakota I could bring in to help, who is a nurse who knows this stuff, but I got pushback from those DONs because basically one word, pandemic. Nobody is really in tune with any big system changes while they're just trying to keep their doors open. And
Right.
you ask the DONs in North Dakota, what's your number one issue? Staffing.
Right.
They're seeing the number of admits related to COVID go down, but at the same
Yeah.
time, the pressure on staffing is the same. So, so I
Right.
think we're going to have to basically put things in front of people and try to get the right people to bite it.
Right. You raise a very, very good point. And I know when I started putting these two together, the first one came right during the re-hit from COVID. And I was thinking, how can you possibly start doing something like this when you don't even have enough staff to deal with all your patients that have COVID and have other emergencies? But I think there are little things that you can do in the interim potentially. Now you mentioned you mentioned VLM or something. I'm not sure what that means.
I was trying to say that DON, directors of nursing in our
Oh, I got it.
hospitals. Yeah, right.
I got it. I think without forcing it down the throat of any director of nursing, again, that individual needs to understand the value of this and needs to buy into it. And at the same time, they need to know that we understand that the pressure they're under right now, the lack of staff that they're having right now, and that we don't want to push them any way further. But if they can begin to think about how we might do this when we begin to have the time to do this, or we feel like we're not, our heads are underwater and we're barely able to breathe. So any little, as a leader, you will need to communicate the fact that you understand you folks are overwhelmed, that you would like to move this forward as we're able to. And I'd like to just think about how we might approach it so that when we do have the time, the money, the energy, or whatever, we're able to gradually do this little bit by little bit. And let's just say, let's start with something simple like maybe coding, or let's start with something simple like the wellness visit. Or, that does involve a whole team, but if you present the whole picture on why all these components are important, but let's now start with just one little thing that we think we can do, at least that could potentially build some success when your staff are ready.
We have had some efforts. One of the things that I think we've done well is we worked with Blue Cross Blue Shield in North Dakota and the Quality Health Associates and also our state health department, and basically put together a care coordination training program. So we have a number of rural providers that have gone through this process, and they go through it as a team. So it's not just one person per facility. They're going through this as with 2 or 4. So there is your own local group, So anyway, so we are making steps. Anyway, but thank you. That was a good answer. I appreciate it.
Thank you. Thank you for that question.
While we wait, I'm going to allow more time for people to ask questions, but I'm going to pull up the post-polling questions as well.
Just out of curiosity, Brad, where are you located?
You're on mute, Brad.
I have that challenge of getting unmuted. There you go.
Most people prefer me on mute. North Dakota, we're the State Office of Rural Health, the Center for Rural Health. So we're located in our School of Medicine and Health Sciences in Grand Forks.
Okay, great.
And while we're doing the polls, I do have one more question, and that is when it comes to like driving this, does it tend to be the CEO? Who tends to be the initiator of all this and kind of driving this team sport forward?
The starting individual is the team captain, and that is really the CEO, the leadership, the very top lead. But just like with any game or any sport, after a while you let your players run the game because they begin to work together and they work well. They still need that support from the CEO or the executive leadership, because they're going to be working hard, and there may be some things that the executive leader needs to know about. And that's why periodically we want to have the clinical leads get together with the executive in order to, and I should say the champions get together with the executive so that everyone knows where we are and any challenges that we're having. But from there on in, you know, it's up to the champions in each of their different areas to be able to troubleshoot, to support, sometimes commiserate, but also to be able to reinforce the value of what we're doing here, and also for them to provide them with small wins as the time goes on. So it's not something that goes away. That's why I would recommend these by the provider lead, let's say these doctor's office hours, that the larger organization have to be part of the grand rounds component, and everyone just be engaged throughout and listen and troubleshoot.
Thank you.
So I have a similar question to piggyback on what Brad said. My name's Liz Craker. I'm from the Utah Office of Rural Health, and we are working with a project with the CDC to help hire a data analytics firm to help rural hospitals break down their data silos so they can be more preemptive and have better population health. But the CEO, a couple of CEOs are like, wait a minute, if this goes to value-based care, then I'll have less traffic in my ER and I won't be able to keep my doors open because I won't have that funding. So I wonder what you would comment about that.
It depends upon how the structure is made. I know that has been a concern of many of these smaller hospitals when I was working at Aledade, because we're really working with private practices. One of the goals is to keep patients out of the hospital. Well, one of our hospitals actually had a team of physicians that were on their staff, and that hospital actually supported it because they were part of the winning of the entire process. So they don't want to see patients necessarily that don't need to be seen or filling up their emergency room when they don't need to be seen. And they also don't want to have patients be readmitted when they don't get paid for that readmission, and it makes their numbers look bad. So the more they're able to support their outpatient community to make sure that the patients are seen and are not coming in unnecessarily, I think it winds up being a success for everyone. And again, it's very dependent upon how the organization is structured, how the reimbursement is structured. And I can't begin to talk about, you know, like when we were implementing an EHR in a practice, you've seen one practice. I'm sure it's the same thing is true with all of those small clinics too. You see one clinic, that's it. They're all different.
Do we have any more questions for Dr. Kleberg?
Well, again, I'd like to say thank you for participating in this particular endeavor. It is a heavy lift. It is something that is good to do on a gradual scale. It's good to involve the leaders within your organization who can see this in a positive light, are good listeners, good problem solvers, and are also willing to say, look, this way is not going to work, but not just leave it there, but to be able to come up with some other solutions so that it will work. Because again, there's there's clear value in this. And I do understand from the hospital perspective how it could be kind of scary. But again, once they understand the true value of this and having these patients accurately risk coded and their potential costs go down, they could potentially, they would be sharing in that shared savings. So in the long run, the hospitals that we had worked with, it worked out for them in the long run.
Well, thank you, Dr. Kleberg, for your great presentation. This is part 2 of the 2 series. So, and thank you to everyone for your participation. The recording will be available within 5 business days on our help webinar playback, and we will link part 1 and part 2 together so you have access to both. I appreciate you taking the time to answer the polling questions. We would also like to ask you to complete the short online assessment, which is in the chat box. If you would like 1 ACHE qualified credit for today's webinar, you must complete that survey to get that. As always, we encourage you to reach out to the RIPT team with any TA questions that you might have. And thank you again for all of your participation. Have a great rest of your day.
Thanks, folks. Bye-bye.